Hello friends, welcome back to my channel in the new set of video. We will have two videos in this particular main section of Sepsis Unplugged from guidelines to the bedside. So here I think it will be better uh, for the students and the trainees to have a fair idea of what is going on in the sepsis kind of important clinical entity as far as 2025 is concerned. And this particular topic I delivered in Ahmedabad. So without further wasting any time, let us move on. So as we know that for an intensivist, surviving sepsis guideline or campaign is like the standard reference point, and they got revised in the year 2021, and now they will have revision in 2026 supposedly. So when we talk about sepsis, obviously screening is important, and the surviving sepsis campaign guideline recommend against the use of Q-SOFA compared with SIRS, NEWS or MUSE. So this was a strong recommendation, moderate quality evidence. So this was one of the important change or a paradigm shift of screening of sepsis from Q-SOFA to NEWS or MUSE or SIRS. And we know that inflammatory cascade is responsible for the all the changes which happens in sepsis, upregulation of the inflammatory cytokines like IL-6, IL-10, and downregulation of the anti-inflammatory cytokines, and that is what is affects the endothelium. So there is endothelial damage, and of course the capillary leak, which is responsible for multi-organ failure. So let us start with a case. So 54 years old obese female with a known case of diabetes, has fever and right hypochondriac pain since last 2 days. She is dyspneic for last 8 hours, and the saturations were borderline on room air, as you could see, and she was in shock. So this is a very typical case of some kind of septic focus inside the body, which is culminating into septic shock. So what do we do next? Of course, we give fluids, which one and how much we will see. So this is, as I said, 2021 best practice guidelines. The surviving sepsis campaign recommends immediate fluid resuscitation in the patients with sepsis induced hypoperfusion or septic shock, crystalloid resuscitation at the dose of 30 ml per kg within the first 3 hours of resuscitation. So this was a classical statement which we know, which was put forward in 2021. We monitor lactates. Of course, we take help of dynamic measures like positive leg raising test and stroke volume variations, and of course the capillary refill time. For so there is one category of patient where uh, they receive a lot of larger volumes of crystalloid and still they are in shock. In those very few number of subset of patients, there is a suggestion of use of albumin in this patient. Otherwise, albumin as a resuscitative fluid is, the concept is not prevailing. So it has to be crystalloid, and surviving sepsis campaign guideline suggest use of balanced crystalloid solutions instead of normal saline for resuscitation. So these are the two take homes from this particular slide. Is albumin is not the first agent. It is of course a crystalloid, and that too a balanced salt solution. And of course there is a dispute regarding this dose of 30 ml per kg. It is not a kind of a rule where you use only 30 ml per kg. Of course you have the targets of mean arterial pressures, CVP, urine output, SCVO2, and normal lactates, and so on and so forth. So, as I said, balanced crystalloid and albumin in few subset of patients, which we should remember. So, we should not have a situation where the patient is too dry and or too wet. So, we want something in between uh, as an optimal fluid strategy, and we need to weigh the risks and benefits of fluid resuscitation in this category of patients. So, as I said, there was a dispute, and what is a dispute? So, before that, we need to know what are the problems with this kind of resuscitation. So, in a paper by Marik et al. In Critical Care 2017, they found that risk of death increases if the fluids delivered in a day is more than 5 liters. And it's very difficult in an emergency situation to assess the actual weight of that particular patient to count the dose of fluid in ml per kg. So we'll end up in having erratic dosage of IV fluids, especially in the emergency setting, where height and weight may or may not be available or they are unreliable. And it has been kind of extensively studied, like one in the anesthesia intensive care therapy 2015 and critical care 2017, and it has been found that the compliance were not kind of followed in even less than 50% patients of CKD, heart failure and liver failure, where they found that in these patients there was no difference in mortality. So the message here is that when the clinicians were away from the guidelines, there was no compliance with the 30 ml per kg. So the fluids can be less in these patients. Still, the mortality was not different. So probably the 30 ml per kg is slightly higher dose what we are aiming for. And we all know what are the harms which are caused by the fluid overload. We know that the fluid accumulation is equal to cumulative fluid balance in liters divided by the patient's body weight into 100. And if 10% of the fluid accumulation, it carries a worse outcome. So it was well studied by Malbrain et al. In 2014. So as we know that high fluid or fluid overload causes increase in the ICP, decrease in the cerebral perfusion pressure, thus culminating into delirium and decreased cognition. It can cause diastolic dysfunction as far as heart is concerned. It causes something called as hepatic compartment syndrome due to congestion of the liver. Lungs, of course, there is hypoxia, there could be hypercapnia, decrease in the compliance of the lung, and pulmonary edema, and of course pleural effusions. In kidney, the resistive index will go up, there is decrease in the GFR, and the renal compartment syndrome which is seen. And ultimately the heart of these problems is glycocalyx. So there is a glycocalycial damage by the fluid overload. Of course, there is also something called as abdominal compartment syndrome, which we all know. So it is a multi-system problem giving rise to the problems related to the fluid overload. Now coming to some evidences and the most important trial which is discussed and important or very favorite questions of the examiner as far as critical care trainees are concerned is Clover's trial. So it was a early restrictive versus liberal fluid management for sepsis induced hypotension. It was published in NEJM 2023 by Shapiro et al. And the conclusions were in sepsis or ARDS patient, deresuscitation or the restrictive fluid strategies were found to have increased ventilator free days and decrease in the ICU length of the stay. As far as mortality was concerned, there was no difference in the mortality, but definitely the ventilator free days and ICU length of stay had bearing on this. So restrictive strategy had bearing on ventilator free days and the length of the stay. As far as RIFT's study was concerned, which was published in Critical Care Medicine 2019, uh, where restrictive fluid strategy trial was in severe sepsis and septic shock in about 109 patients. So restrictive strategy used around 47 ml per kg IV fluid versus the usual care, which was about 60 ml per kg. So they found that the average duration of ventilation was only 16.8 hours versus about 37.8 hours, which is about just more than double of uh, the restrictive fluid strategy. So it was definitely having the impact on the duration of ventilation, and it translates into the fluid management even in the septic perioperative patients, where Dr. Prashant Nasa and Malbrain et al. Proved that even in the perioperative patients who are septic, a personalized fluid resuscitation of about 10 to 20 ml per kg ideal body weight is sufficient for these patients for resuscitation. So we are probably going a little, there are definitely indicators and signals towards problems related to this resuscitation of 30 ml per kg. I'm sure there are trials which are going on, and we will get the results soon. Of course, it will get reflected in the 2026 Surviving Sepsis Campaign guidelines, the revised ones. So, the message here is that it's not necessarily that every time we kind of deliver 30 ml per kg to all the septic patients or septic shock patients who come to ER or in our ICUs. So this is what the message is, and I think I'll stop here. We will continue with the part 2 in the next video. That's all for now. Thank you.